Adenocarcinoma and urinary bladders. Adenocarcinoma is an uncommon malignancy in the urinary bladder which may arise primarily in the bladder as well as secondarily from the number of other organs. The bladder adenocarcinoma may be primary or secondary. The secondary adenocarcinomas are more common than the primary adenocarcinomas. And this primary adenocarcinoma of the bladder is derived from the urothelium of the bladder but exhibits a pure glandular phenotype. It is seen in the 6th and the 7th decade of life. And hematuria is the most common symptom, but some patients may present with bladder irritation symptoms and rarely mucosuria. Approximately 1/3 of patients have lymph node metastasis at the time of presentation. And the risk factors are 90% of bladder tumors in the patients seen in the extrophy of bladder or adenocarcinoma, and up to 10% of the bladder cancers are adenocarcinomas in the areas where schistosomiasis is endemic. Other possible risk factors include chronic irritation, obstruction, cystocele, and endometriosis. Grossly, bladder adenocarcinoma usually arises from the trigone and the posterior wall but can be found anywhere in the bladder. It usually presents as a solitary lesion, unlike the urothelial carcinoma, which tends to be multifocal.
Remember, I told you this, that usually TCCs tend to be multifocal. NMIBC tend to be more multifocal than MIBC. And adenocarcinoma is usually one solitary lesion.
Grossly, the tumor may appear as a papillary, sessile, solid, or ulcerating lesion. The cut surface is often gelatinous due to the abundant mucin production. Histologically, bladder adenocarcinoma exhibits various growth patterns like enteric, mucinous, signet ring cell, not otherwise specified, and mixed patterns. Enteric pattern is composed of intestinal type of glands with the pseudostratified columnar cells and nuclear atypia closely resembling the colorectal adenocarcinoma. It may produce intracellular or extracellular mucin, and necrosis is not infrequent. Mucinous pattern will produce abundant extracellular mucin with the tumor cells floating in a pool of mucin. Signet ring cell pattern is composed of diffusely infiltrative, poorly differentiated cells with prominent intracellular mucin and indented eccentric nuclei. These tumors tend to present at an advanced stage and carry a worse prognosis than other variants. Not otherwise specified type has a non-specific glandular growth, and the tumors with more than one pattern are classified as a mixed types. In addition to the above mentioned variants, very few cases of hepatoid variant of adenocarcinoma have been reported in the literature. These tumors mimic hepatocellular carcinoma and express alpha-fetoprotein, HepPAR1 and alpha-1 antitrypsin. The tumor cells have abundant eosinophilic cytoplasm with the hyaline globules arranged in the solid sheets and trabeculae. Bile production can also be seen. Diagnosis of primary bladder carcinoma should be made only after exclusion of secondary involvement by adenocarcinoma from other organs. The secondary adenocarcinoma.
That's an important line. That's why it's important to make sure you do an endoscopy, sigmoidoscopy of all these patients. Make sure you've done something with their bowel. Take a history of colorectal cancer in the family. Very important.
Secondary adenocarcinoma. Secondary adenocarcinomas may arise from the colorectum, prostate, female genital tract, breast, stomach, lungs, and other sites. They may spread by direct extension or by hematogenous or lymphatic route. It may be challenging to distinguish primary from the secondary adenocarcinoma in the bladder. The histological findings often need to be correlated with the immunohistochemical study and the clinical history to reach the correct diagnosis. The management and the clinical outcome is majority of the patients with the primary bladder cancer have a muscle invasive disease, and these patients are treated with radical cystectomy and the pelvic lymph node dissection. Primary radiation therapy may also be considered for some patients who are not appropriate for cystectomy. The efficacy of primary radiation therapy in comparison to the surgery is unclear due to the limited experience with this rare disease. The traditional cisplatin-based chemotherapy regimens like MVAC that are used effectively for urothelial carcinoma appear to have a little impact on the adenocarcinoma. And the minority of the bladder adenocarcinomas may present as non-muscle invasive tumors, and these patients are often treated with cystoscopy and the transurethral dissection of the tumor. Some patients may also respond to the intravesical therapies with BCG and mitomycin C. Most patients will experience tumor recurrence and the progression after the local treatments. Urachal adenocarcinoma is treated differently from the bladder adenocarcinoma. The standard of care is en bloc resection of a bladder dome, urachal ligament, and umbilicus. And as up to 7% of urachal adenomas involve the umbilicus, the relapse rate is generally higher in the patients that do not undergo en-bloc resection. Bladder adenocarcinomas has a poorer clinical outcome than the urothelial carcinoma, and aggressive behavior of the bladder adenocarcinoma is likely due to the frequent presence of advanced disease at the time of diagnosis. When adjusting for the tumor stage and the grade, the recent studies display the similar survival outcome between the urothelial carcinoma and the bladder adenocarcinoma. And the urachal adenocarcinoma patient appear to have a better prognosis than the primary bladder adenocarcinoma. Favorable prognosis is due partly to the fact that urachal adenocarcinoma is often diagnosed in the younger patients than those with the bladder adenocarcinomas. Thus, it is associated with fewer comorbidities. A 5-year overall survival is more favorable for the patients with urachal adenocarcinoma than those with non-urachal adenocarcinoma, even after adjusting for grade, histological subtype, stage, age, gender, and surgical management. Intrinsic anatomic and the molecular differences between the urachal adenocarcinoma and the bladder adenocarcinoma may also contribute to the different clinical outcomes.
Very good. Okay. Thank you.
Thanks.
So now we have a full understanding of adenocarcinoma, bladder, old people, but it's all based on the case that we discussed last week. So you guys must be upfront on what Kamlesh has said and what Dhanush has said on this. So next time we have a case, don't be floundering. We have enough information. Sujata, can we take your case discussion tomorrow?
Yes, sir, no problem. We are free tomorrow.
Yeah, okay. We'll see. Can we do it tomorrow morning?
Yeah.
You're okay?
Yeah, okay. Yeah.
Wednesday. Thank you.
Thank you. Thank you, sir.